One of you, can you please confirm whether you can see my screen? I've opened brain abscess.
Yes, we can see it now.
Now we can hear you also.
No fibrous capsule, right? So there is.
Repeat again the definition.
Abscess is defined as localized collection of pus surrounded by the zone of gliosis, brain abscess. Localized collection of pus surrounded by the zone of gliosis is responsible for the pus. So in streptococci, we have streptococcus. In staphylococci, we have staphylococcus aureus, one of the most important organisms. Then what are the sources of infection? Hematogenous spread, and direct inoculation. In hematogenous, it is the organisms, they are coming from the vegetations which are present in the valves of the heart, like from the subacute bacterial endocarditis. So the vegetations, they contain live bacterial colonies, and these vegetations, they become emboli, and they may cause abscesses not only in the brain but different parts of the body. And usually they break into hundreds of tiny pieces, microemboli. So that's why the patient might develop multiple brain abscesses. Then the next is lung abscess. So from the lung abscess, the bacteria enters blood, hematogenous spread involves brain. Similarly, from the bronchiectasis. The next is from the tooth extraction. So in tooth extraction, the most important reason for tooth extraction is dental caries, which contains bacterial colonies. And during tooth extraction, the capillaries, they rupture, and the bacterial colonies, they easily enter blood, and from there they involve brain. The next is direct spread. So direct spread, it means from close proximity, and this spread is via continuity or by contiguity. So what are the now if you look at the examples, otitis media, mastoiditis, sinusitis. So all these structures or the infections, they are in close proximity to the brain. So otitis media, commonly seen in children, otitis interna, again commonly seen in children. So it is in close proximity to the brain. Even infection in the mastoid bone, mastoiditis, again it is closely related to otitis media, again commonly seen in children. So infection from this side, they are in close proximity to the brain. So development of brain abscess. Then another example is superior sagittal sinus. So we discussed this extensively at the time of lecture, right? What is superior sagittal sinus? So thrombophlebitis from there easily involves the surrounding brain, and there is formation of abscess. Then the next is direct inoculation, direct entry of the bacteria. So this is usually seen in crush injuries, particularly road traffic accidents. So crush injuries of the head, rupture of the laceration of the dura, the brain is exposed to the surrounding atmosphere, dust, debris, and the bacteria directly enters inside the brain. Now, what about the clinical features? The most important one is the brain abscess. It acts as the SOL, Monro-Kelly doctrine. If you remember, we discussed extensively in detail what is Monro-Kelly doctrine. So this lesion acts as a SOL, space occupying lesion. So patient develops headache, nausea, vomiting, confusion, coma. Then next, because of the infection, the patient will develop fever. The most important manifestation of infection will be fever, and other features like fatigue, loss of body weight, loss of appetite, right? Then next, the most important feature is the neurological deficit. Because of the damage to the neurons, the patient will develop focal loss of neurological function, which is called as focal neurological deficit. And depending upon the site, the patient will have neurological deficit. And we can summarize this into a triad, into three important features. Again, this I discussed at the time of the hospital discussion. So fever, headache, and focal neurological deficit. So these are called as triad of the brain abscess. So clinical diagnostic features of brain abscess. Now, how do we investigate? CT, MRI. The most important is the MRI examination, and then you should find out the source of organism. And usually the abscesses, they are seen at the junction of the gray matter and the white matter. And depending upon from where they are extending, the patient will develop the brain abscess depending upon the site extension, right? So from the otitis media, the abscess is usually seen in the temporal lobe. If the infection is spreading from mastoid bone, the abscesses, they are seen in the cerebellum. From the frontal and from the ethmoidal sinuses, the abscesses, they are seen in the frontal lobe. So gross, we already discussed. Well-defined discrete lesions. There is a margin of the brown ring, and there is central depression of liquefactive necrosis. So again, here there is a large abscess in this image and showing shift in midline towards the opposite side. So we discuss this in great detail at the time of lecture, shift in midline. Then the microscopic features we just now discussed in the OSPE examination. Right. Now, what about complications? The most important complication is abscess rupture. So when we say abscess rupture, it means a rupture of the zone of gliosis. And depending upon where the abscess is located, if it is present near the ventricle, it may cause inflammation of the ependymal cells, ventriculitis. If it is present near the meninges, it may cause meningitis. And if it is present near the superior sagittal sinus, it may cause superior sagittal sinus thrombophlebitis. So again, this is two ways. Superior sagittal sinus thrombophlebitis may lead to brain abscess, and brain abscess may cause development of superior sagittal sinus thrombophlebitis. And the next dangerous complication is herniation syndrome. All right. Now, regarding prognosis, early diagnosis is very important, right? Even after so much advancement in diagnostic, so much advancement in antibiotics, still the mortality rate is quite high, we can say. The next is subdural empyema. So what is subdural empyema? It is the collection of pus between the two layers. So in this situation, it is between the dura and the subarachnoid and the arachnoid membrane. So between the dura and the arachnoid membrane. And the reason is again pyogenic bacteria, staphylo, and in some situation it might be because of some fungal infection. And from where the organisms they are coming again from the direct source, that is the osteomyelitis and the sinusitis. Clinical manifestations almost exactly same like the brain abscess with additional feature of neck stiffness. So again, we discuss extensively at the time of the lecture why neck stiffness, right? It is because of the meningeal irritation. Now, regarding complication, the patient develops the patient presents with mass effect, that is the features of SOL, and the patient may also develop thrombophlebitis of the bridging veins. What are bridging veins? We discussed in the previous lecture. So these bridging veins may develop thrombophlebitis, and because of the thrombophlebitis, patient might develop brain infarction because of the obstruction to the outflow of the blood. So again, here early diagnosis and treatment is important. The next feature, the next pathology is tuberculoma. Now again, look at the name tuberculoma. It's a misnomer because when we say tuberculoma, it implies that we are discussing tumor, but it's not a tumor. Basically, it's a tuberculous infection caused by Mycobacterium tuberculosis. And these lesions, they are usually seen in patients who are suffering from AIDS or patients who are immunodepressed. So infection from the lungs enters blood, and from blood the organisms they reach brain and they form a lesion which is called as tuberculoma. Now, why it is called tuberculoma? Because it simulates like a brain tumor. It forms a small intraparenchymal brain mass. It forms like a tumor. So that's why it is called as tuberculoma. But it's not an actual tumor. And sometimes the infection may also spread and involve meninges. So this is a well-defined lesions which resemble like a brain tumor. So this is called as tuberculoma. And what are the microscopic features? We know tuberculosis anywhere in the body. The pathognomonic lesion is called as caseating granuloma. So caseating granuloma, it is composed of central caseous necrosis surrounded by the modified macrophages which are called as epithelioid cells, Langerhans giant cells, and lymphocytes. So this is a caseating granuloma. And then we can confirm it by doing acid-fast stain in the form of Ziehl-Neelsen staining. So we will find acid-fast bacilli, or you may do PCR examination. Now the clinical manifestation, look at the features. So again, this resemble the clinical manifestation. They resemble like clinical manifestation because of the brain tumor. So that's why because of the clinical manifestation and because of the MRI manifestation, this tumor, this lesion, it simulate brain tumor, right? So sometimes it might get misdiagnosed as a brain tumor. So you should remember that even like sometimes tuberculoma